Hi everyone, and shut my audio because we have enough audio from there. So this is our subluxated lenses and flanging lenses course. Since everybody else is busy in Rangachari, uh, I think I'm going to take some more time. Let's go through 3-4 different clinical scenarios. So this person was lying in a hotel by the swimming pool and a mango fell on her eye. That's why I made this video called Mango Season. When anybody gets hit on the eye or anything happens and they go to the GP, they always get Ziplocs. At least in Maharashtra and Goa area, anything happens, GP puts Ziplocs in the eye. So she put Ziplocs for a few days and realized vision is not improving and then comes for a consultation. On presentation, IOP was about 50 with a clear cornea, mid-dilated pupil, and the lens luxating into the anterior chamber. So I gave a mannitol IV and an oral Diamox, waited for the IOP to drop somewhat, and then we start the case. So let's have a look at this. So this kind of scenario, we always keep a Emmet segment ready, a ring segment, keep an anchor, keep different sutures, everything ready, and always the ubiquitous CTR. So you need the biggest CTR that you can have to give the bag stability. And to start this kind of case, you can see the whole lens is a little mobile, but there's not like one particular area from which it is totally subluxated. So it's like a general zonular laxity due to the blunt trauma. So you make a nice smallish rhexis, about 5 mm, and then you open your little armamentarium of capsule hooks. You always wonder, I used to always wonder why there were 4 hooks. Was it, with there 5 hooks, was it that if you drop one, you have one extra? But not really. The 5 hooks are actually used to suspend the capsular bag like this. So if you have a good rhexis, which is paramount in this kind of scenario, otherwise you cannot do this maneuver, your capsular bag is now completely stable and you can see it is transfixed. So it's not going to move at all. You can do your phaco maneuvers. You have to go a little slow. You can't use 700 vacuum, otherwise the bag might flop off. And again, you do a gentle irrigation aspiration. This is important because you don't want to dislodge the capsular bag from its hold from the hooks. Because if you dislodge the bag, then getting the hooks back may be difficult. So you slowly peel the cortex from the periphery to the center using low vacuum and low parameters. And now it's time to inject the capsule tension ring. So preloaded rings, this was an imported ring this was videos about 4-5 years old, but now you get them from many Indian companies. And these preloaded polypropylene rings are very nice. And they make PMMA as well. So this is particularly a PMMA ring from a company called Offtech, which goes in like butter. That's very important. It'll never snag the capsular bag. And in goes the IOL. I tuck the IOL into the bag and see, is it sitting nice and stable? And surely enough it is. And this patient still comes for follow-ups. At any sign of zonular laxity, I will think about passing a suture through the haptics and fixing it to the sclera, but not now. So far, everything seems to be good. So when you have a case of gross subluxation, not like this, you have 90 to 180 degrees totally subluxated, you can either use a ring segment or you can use a fixation device like an ASIA anchor, which was invented by Ehud ASIA, and it's in its second generation now. The first generation that I'm going to show you was uniplanar, and the second one is three-dimensional like a paper clip. So let's have a look at this video now.
Should we use capsule hooks or simply
Stop the
drop
audio.
anchor when required in the case of?
So basically, what should we do in this kind of scenario? If you have access to a femtosecond laser, now is the time to deploy it. Instead of using the femto to do grade 1 cataracts, which is just pointless, you have to use it for situations like this. You get a perfect punched out rhexis like this, and to get a rhexis like this is rather difficult to get every time by hand. So in this kind of scenario, this works well. Use Helon or sodium hyaluronate to make some space there and then put capsule hooks. Capsule hooks are different from iris hooks because the capsule hooks are broader at the end and they are blunt. So it won't hurt the capsular bag at all. That's your ring segment. So you pass one end of a double arm proline and railroad one end out of the eye and then railroad the other end. So you have a 2-point fixation like this in order to hold the ring segment properly. This is all rather simple maneuvers. Get the ring segment, and you can see the capsular tension ring as well there. So you always put a capsular tension ring along with the ring segment. So what do you do if you have a poor axis? What happens when the femto doesn't work or the subluxation is so extreme that it exceeds the parameters of the femto system like this? So it made some punctures in the cortex, but it didn't make any capsular axis because it just couldn't compute it. So in this kind of situation, you are stuck doing it manually. Most of the time it does work out, but this time it didn't. So take it around, and now the rhexis has tried to run away despite frequently putting viscoelastic in the eye. So I managed to keep a rhexis, but it's gone to the periphery. So the equator of the human lens is involved in the capsular rhexis. In this kind of situation, you don't have enough rim for the capsular segment to hold itself in. It will just pop out of the bag. So you take out your double arm Prolene again, and this is an anchor, which looks like an anchor that you throw from a boat to keep it stabilized in the sea. So it has two legs at the end. And those two legs are what we are going to use to entrap the periphery of the capsular bag. So railroad the suture out of the eye and keep your anchor in there to give some kind of stability in case the capsular bag looks like it's going to fold over once you take out the cortex. Luckily, this didn't happen. So the capsular bag was quite stable in this case. After doing an IA, I create a new posterior capsular bag by pulling the anchor with its two trailing legs, which has enmeshed itself in that periphery. Pass the suture twice through the sclera. So you need only one pass. You don't need a double arm. You can do a double arm, but I think this is just easier. You pass one suture after tying it and then pass it twice through the sclera. It locks it. So now you've generated a decent usable capsular bag. And now you can put your IOL in there. When you inject it, see that you don't just inject it quickly inside. Otherwise, it will jump open. It hits that anchor, and the anchor loses its hold on the capsule. It will just fold over and become very complicated. So this was the end of the procedure, and this case ended well. So let's have a look at another unique case where I had to flange a lens. So this person, somebody had operated them and obviously had a PC rent. And then he put the PC lens, which was a three-piece foldable with polypropylene haptics in the anterior chamber. And this remained there for years together. When he came to me, a totally decompensated cornea. The record showed that after that, he went to a retina specialist who then there was probably some fragments in the vitreous, and he did a 3 ppv. So now you had an eye with no vitreous, no capsule, and the PC lens in the AC. So in this kind of situation, we have to get the lens out because the cornea is totally packed up. And then after that, we have to plan a DSEC. But a DSEC we can only do when there's a lens behind to hold the air bubble. So first we have to flange a IOL and then do a DSEC. So let's see how this went. So first step, we know that we're going to do a DSEC and get that out. So you need a nice big tunnel, about 5.5 millimeters. So you do a scleral tunnel and get that IOL out that has been living there in the anterior chamber. Already vitrectomy has been done, so I can just put an AC maintainer rather than a posterior port. 1.5 to 2 millimeters, you measure, and then load up the needle just as you saw in the last few videos. Put the needle in, then go through the main tunnel after shutting off the infusion, otherwise the iris jumps out, and then get one end out. At the same time, you prepare that graft and get it ready. So flanging a lens like this is rather straightforward. Since we have a big opening, I might as well just use a PMMA lens with eyelets, which makes it nice and simple. So you pass those through two sutures through the eyelets of the PMMA lens. And this is the trailing haptic where you're passing it. And remember that the flange has to be inferiorly to hold it. So that's the whole complex. You pop it into the eye. and then use your low temperature cautery. Now, second part of the surgery. And that's your graft getting in the eye. Now you close all the openings and make it absolutely airtight and then float it up. So DSEC is a simple surgery to learn, especially if you get pre-cut grafts. It's rather simple. It looks very complicated, but it's not. You can see videos and you can just do it yourself. Put all the sutures, make sure that air bubble stays, and this patient still comes back with pretty good vision. He's about 6 by 12. And this is the final situation that I wanted to share with you all since we have lots of time and no other speakers. Uh, it's pediatric cataract with persistent fetal vasculature. So all of us who did MS in the 90s would know this as persistent hyperplastic primary vitreous, where the hyaloid artery and sometimes tunica vasculosa lentis is left behind. Post 97, it became PFV or persistent fetal vasculature. And you have eyes with anterior PFV and posterior PFV, and then you have eyes with both of them. When you get a small baby with a unilateral cataract, you must understand that 90% of the time, this child is going to have PFV. So if you prepare only for cataract surgery and don't do a B scan and other posterior investigations, you'll get blindsided when you remove the cortex and you realize that there's a hole in the posterior capsule, or there's a plaque there, or there are fetal remnants. So expect some persistent fetal remnants in unilateral pediatric cataract. Let's have a look at the video. So the baby was referred to us from the Middle East with all the investigations done. B scan, IOL power calculation, everything. So that's what it looks like. And you can see that the posterior capsule plaque. So first thing is that you put in a pot about 2 millimeters behind. Because once you do the cataract surgery, the eye will be so soft in an infant, you won't be able to get that pot in. Use the side pot and do a nice, slow, controlled rhexis with lots of viscoelastic. You don't want that rhexis running out. Just suck out the lens matter. And lo and behold, what we predicted was there. There's a posterior capsule punched out opening. So we already know this, that this was going to be there, because 9 out of 10 times this is going to be the scenario with a posterior capsule plaque. So in goes the IOL. And the IOL tamponades this opening, and this opening is quite stable and doesn't show any signs of extending to the periphery. And you can see part of the plaque on the side. So let's go to the vitrectomy part of it. That's the B scan showing the posterior hyaloid artery and multiple echoes there. So we have to clear all this off. Luckily for us, posterior hyaloid artery didn't bleed at all. The artery inside had regressed and there was only fetal remnants left there. So we could just do a vitrectomy and get it out. So these are the few situations that I wanted to share with you.